laboratories from different institutes and my senior and colleagues. Assalamu alaikum. So today we are here to discuss about the youth onset diabetes, and in two presentations we will discuss about monogenic and polygenic forms of diabetes respectively. The topic may not be related to our day-to-day clinical practice, may seem boring. We will try to summarize as much as possible and try to make the important part of this topic to present before you. So let's start with the youth onset diabetes. Synonymous to early onset diabetes, young onset diabetes, this youth onset diabetes is a great concern for us, because this diabetes mellitus in young is the unclassified gray area. If we think in a child less than 10 years of age, the cause of diabetes is most commonly type 1 diabetes mellitus, and in rare forms monogenic neonatal diabetes mellitus. And in persons aging more than 35 years, the most common cause of diabetes is type 2 diabetes mellitus. But what about in between 10 to 35 years of age? They have some overlapping features of type 1 or type 2 diabetes mellitus or other forms of diabetes. Sometimes it becomes difficult for us to distinguish the cause. And to characterize this group of patients, this group of subjects, we started working on this almost 8 years back. This group was formed under the leadership of Professor M.A. Hassan sir. The group is called Study on Diabetes in Young Group. I am going to show some data of this group. Although we have worked in lot of aspects, I am focusing to my part, monogenic form of diabetes. So only a part of data is shown here. In analysis, we analyzed 128 youth onset diabetes patients, and among them only 20% had positive anti-GAD and zinc transporter 8 antibody. The rest, 80% actually are antibody negative youth onset diabetes. And among them, 36% only are obese with a BMI more than 25 kg per meter square. Rest 44% are antibody negative. They are non-obese, but they have youth onset diabetes. They have no typical characteristic of either type 1 or type 2 diabetes. So where does they fit in the classification of diabetes? We know WHO has classified diabetes in 2019 as type 1, type 2, hybrid forms and other specific forms. This group of patients does not fit well in type 1, type 2, as they are antibody negative and not ketosis prone. Hybrid form also does not fit. So do they fit in other specific types form? In the other specific types, one important type is monogenic diabetes. And we often cannot identify the genetic cause of our patients. So this aspect is often not taken into account. As the name implies, monogenic diabetes mellitus means diabetes that is caused by defect in a single gene. Although a single gene may not be enough to expression of a disease, these disorders which I am going to focus now are caused by defect in a single gene. And what are the importance of identifying monogenic diabetes mellitus? Yes, it is important to identify this group, because if we can identify the underlying genetic cause, we can predict the clinical course of diabetes. We can look for the extrapancreatic features that may be present under this genetic umbrella. Screening of family members can be possible. Genetic counseling will be possible, and we can precisely detect which type of treatment may be appropriate for this group of patients. Now the question is what are the types of monogenic diabetes mellitus? We can broadly classify monogenic diabetes into three forms. One is monogenic defect of beta cell function. Another is monogenic defect in insulin action. So in the second one, the insulin secretion is okay, but there is defect in insulin action. This group includes disorders that results in increased insulin resistance, and different lipodystrophy syndromes are included under this umbrella. The other part is genetic syndromes associated with diabetes, like Down syndrome, Friedreich's ataxia, Martinic dystrophy, and others. As the clinical presentation is dominated by other features other than diabetes mellitus, our focus mostly is on monogenic defect of beta cell function. Under this term, we have got MODY, that is the maturity onset diabetes in young. We know there are 14 types of MODY already identified. There are some other disorders which are also included under this term, like mitochondrial diabetes, Wolfram syndrome, and some rare syndromes also. I am going to focus today on the maturity onset diabetes in young. So it is an autosomal dominantly inherited diabetes, and despite a young age of onset, is not insulin dependent. It results from beta cell dysfunction rather than insulin resistance. Now the question is, how common is it? If it is very rare, why we are spending time on this matter? Actually, in prevalence studies, it is seen that this disorder is not that common in Europe, United States, and Australia. The prevalence is only 1 to 5% of all diabetes mellitus cases. But in our population, and even in populations of Africa, Asia, South America, the true prevalence of MODY is not that much known. And it is a possibility that we may underestimating MODY, because due to poor referral rates for genetic testing, approximately 80% of MODY cases, even in United Kingdom, are thought to misdiagnosed as either type 1 diabetes mellitus or type 2 diabetes mellitus. So it is very possible that we are missing cases which are actually MODY, but we are managing as type 1 or type 2 diabetes mellitus. And in reality, different studies has observed about 15 to 18% cases of youth onset diabetes are actually caused by maturity onset diabetes of young, monogenic diabetes. Now, what are the types of diabetes? Types of maturity onset diabetes in young, types of MODY. So there is a long list which we are not going to discuss today. This list includes the gene which is responsible, the function, the pathophysiology, etc., etc. But to understand this, we will go through the basic pathophysiology of this type of diabetes. And for this, we will go through rapid recapitulation of how our beta cell actually works. So when the blood glucose increases, glucose enters into the beta cell, and after entering, it goes to the glycolysis pathway by the enzyme glucokinase. After glycolysis, the glycolysis products enters the Krebs cycle in mitochondria, and by Krebs cycle and glycolysis, ATP is produced. As a result, ATP-ADP ratio in the beta cell is increased, causing closure of the ATP-sensitive potassium channel. It results in depolarization of beta cell and opening of voltage-gated calcium channel. As a result, extracellular calcium enters the cell and causes exocytosis of the granules containing insulin. And we must remember, this insulin is coming from the transcription translation process, which is operated by mechanism in the nucleus, ribosomes, and extraplasmic reticulum, endoplasmic reticulum. So if any part of this mechanism is hampered, the patient may develop diabetes due to defect in beta cell function. So let's see this picture, where things can go wrong in this beta cell mechanism. We can see that when glucose enters, it is first enters to the glycolysis pathway by the enzyme glucokinase, and if glucokinase enzyme is deficient or not much active, then patient may develop a specific type of MODY, which is called glucokinase or GCK MODY. It is also called MODY2. thereafter, if there is a defect in the voltage sensitive potassium channel, then again membrane will not depolarize and insulin secretion will not occur. So if the genes encoding for this potassium channel is defective, then also insulin secretion may be hampered, and these two type of MODY, MODY 12 and MODY 13, causes defect in potassium channel. Vast majority of the MODY are caused by defect in the transcription factors. So lots of transcription factors are needed for synthesis and processing of the insulin to be available for secretion. And these are the most common types of MODY variant. Other process like endoplasmic reticulum activity can be also involved in some types of MODY. So in general, there are 4 areas where MODY can affect. One is the glucokinase enzyme resulting in GCK MODY. We will see this glucokinase MODY forms about 1/3 of total MODY cases. Another important is the transcription factor MODY, which includes a lot of MODY subtypes, and this is also very much common. The other 2 types is not that much common. One is defect in the potassium channel, and another is the defect in the endoplasmic reticulum system. Now, if we see the prevalence of subtypes of MODY, we can see here that about 1/3 of the cases is caused by GCK MODY, and rest 2/3 is caused only by 3 subtypes of transcription factor MODY. The majority of cases is caused by HNF1A MODY and HNF4A, HNF1B. These are the cause of other common type of transcription factor MODY. Other MODY subtypes are very rare and forms only less than 1% of MODY subtypes. So let's discuss shortly about the common types of MODY variant, that is GCK MODY. As we have seen, it is caused by defect in glucokinase enzyme. When blood glucose concentration rises, this glucokinase enzyme deficiency is overcome and glucose actually enters into the glycolytic Krebs cycle pathway. So these type of MODY patients develop only mild fasting hyperglycemia, and they do not develop that much of postprandial hyperglycemia, and their postprandial glucose rise is usually not more than 3 millimole per liter. These patients are usually asymptomatic and may be incidentally diagnosed during pregnancy. In this type of MODY, microvascular complications are rare and pharmacologic treatment are rarely needed. If needed, it may be required only during pregnancy. And about transcription factor MODY, we have seen there are various types of transcription factor MODY, and clinical picture depends on which MODY gene is affected. But these patients are generally symptomatic and they have progressive hyperglycemia. Frequent microvascular complications are there in this group of patients. Regarding the pharmacological problem, as these patients are usually lean, there is no that much insulin resistance, so they are very much responsive to secretagogues like sulfonylurea. And a specific type of MODY we have seen, MODY 12 and MODY 13, which actually causes defect in potassium channels. They respond very well to sulfonylurea because we know sulfonylurea receptor is situated in that particular channel. So in certain stage of MODY, there might be very good response to secretagogue sulfonylureas. But thereafter, along with the progression of the disease, the patient may also go to need insulin also. There are some extra pancreatic features which are very much important to identify these cases. Like most common variety of MODY, MODY 3, that is HNF1A MODY, is characterized by low renal glucose threshold. So there is inappropriate or more glycosuria than hyperglycemia. There is also raised HDL, but despite having raised HDL, their cardiovascular risk is higher. Another common type of transcription factor MODY, HNF4A MODY, or which is MODY 1, it is characterized paradoxically by increased birth weight and neonatal hypoglycemia. It is caused by increased activity of this beta cell rather than reduced activity during the neonatal period. This type of MODY is also characterized by low HDL and raised LDL. And very important subtype of MODY is the HNF1 beta or MODY5. There are many extrapancreatic features, and endocrine residents may recall a case we recently discussed in our department, which have many extra pancreatic manifestations in addition to diabetes, and which may be explained by this type of MODY. And this group of patients had neurological features including short stature. They may have abnormal liver function, developmental kidney anomalies, and anomalies in the genital tract, including hypoplasia of the uterus. So how will we treat this type of patients? As I have already discussed, treatment will depend on the subtype of MODY. The GCK MODY need no routine therapy, and insulin therapy during pregnancy may be indicated. Another common type of MODY, transcription factor MODY, and MODY caused by defect in the potassium voltage gated potassium channel, ATP sensitive potassium channel there. Then they have good response initially, at least, to diet and sulfonylurea, but insulin requirement is increased with time. Other rarer form of transcription factor MODY and other type of MODY require insulin more than the previous one. Now question is, when we will test our patient for MODY gene? The recommendation by American Diabetes Association is children and young adults with diabetes without typical features of type 1 or type 2 diabetes need MODY genetic screening. And without typical features of type 1 or type 2 diabetes means there is negative diabetes associated antibodies, no obesity, lacking other metabolic features, especially with strong family history of diabetes. Although in our setting it is very difficult to get the proper family history, because maybe before one generation even we do not know the status of our grandparents, the glycemic status of our grandparents. And another indication is the stable mild fasting hyperglycemia, which may indicate the GCK MODY. But the sensitivity and specificity of these recommendations is very low. So there are many calculators which are developed for calculating MODY probability. And this calculator is very useful, which is developed by University of Exeter, United Kingdom. And after applying this calculator, we have seen that about 31% of our young diabetes patients have high probability of MODY. So we know now that they have high probability of MODY. They need genetic testing. But how to test for MODY? So to test MODY, we can go sequencing approach if we suspect only a specific type of MODY, which is guided by the clinical phenotype. Or when it is not possible to determine which type of MODY the patient may have, we can go through the gene panel testing by next generation sequencing, which is the most advanced method of genetic sequencing, and it is now available in our country. And we are going through a study by which we are now screening MODY genetic pattern in our patients with youth onset diabetes. And in this study, we are enrolling patients with diabetes patients who are aging 11 to 35 and recently detected diabetes. So I will request all to refer the patients to our young diabetes clinic. I have come to the end of my presentation. I would like to acknowledge all the members of our SODI group, my supervisor and professors in the department, my colleagues, and the sponsor, scientific partner of this session. Thank you so much. This is my email address. If anyone thinks that the slides will be helpful, please mail me. I will send the slides to you. Thank you very much for your kind patience.